And good morning, good afternoon, good evening, everybody, depending where you are. As Nuran introduced me, my name is Hesham Hassan. I greet you from California in the United States, and I hope all of you are doing fine and keeping safe. So today I'm going to talk to you about slim body, greasy liver. Some of you, may have heard me before talking about fatty liver. I still going to talk about fatty liver today, but from a different angle. Before I start, I have a confession. I may sound brave, but when it comes to public speaking, I'm really a coward. What you're looking here at is the cover of one of my favorite books. It's called I Would Rather Die Than Give a Speech. Actually, this book was gifted to me by my daughter, Yasmin. And by the way, this shoes, which is worn out, it's not mine. It's one of the speakers who was trying to give a public speech, then he fell to the floor. So, you're all familiar with NAFLD, non-alcoholic fatty liver disease, but few of you are familiar with FOO. Do you know what's FOO? It's fear of obesity. We live in a society where people are either overweight, obese, or very thin. I have 2 kids. They are very thin. Their mom has been chasing them for years, trying to feed them by force, and they refuse to eat. And they say, "Mom, thin is in, fat is out." The dream of kids at their age in this society is to fit in and being accepted by their peers and colleagues. And one of the things about the society is the fact that if you are overweight, you are not liked and people don't really want to associate with you. This is an old poem, which will tell you how people used to see beauty maybe 100 or 150 years ago. I will say it first in Arabic. إن المتانة في الأجسام يصحبها متانة العقل والتفكير والحلم. ماذا يسرك من جرداء ناحلة كأنها ريشة تزهو على علم. ما المرأة الحق إلا من إذا درجت يكاد يهتز وجه الأرض للقدم. People saw that beauty has to be associated with being overweight. This was 100 or 150 years ago, but it is not the same anymore. So basically the poem said that, in order to have a sound mind, you have to have a solid body. And the true beautiful woman is the one, when she walks, the ground will shake beneath her feet. Something, similar to this slide. This is a real beauty. You walk and you're going to shake everything. We know that the problem of obesity has grown tremendously over the last 3 decades, and it has actually tripled over the last 20 to 30 years. And we all know that 6% of the overweight people and 10% of obese subjects have high ALT. Take you back to 1985, where, you look at the blue color, it represents states where overweight or obese people used to constitute like 10 to 14% of the population. This was back in 1985. Now we look at 2017. Now we have different colors. Blue, you have yellow, you have red, and you have brown. The red color represents states where obesity is 25 to 29% of the population, while the brown color in these states will indicate states where obesity affects more than 30% of the people. Why should we care about it? You all know fatty liver can be benign or it can be serious. It can start by simple steatosis. It has a spectrum of severity. Can progress to NASH or non-alcoholic steatohepatitis, or it can develop to cirrhosis. Simple steatosis, you start to get inflammation here. We see infiltration of inflammatory cells, and you can end up in cirrhosis. You know a lot about fatty liver, and you probably had a few lectures in this webinar. And we know that the most effective treatment until now, we don't have a perfect treatment for fatty liver, is diet and exercise, losing weight. The problem we face as healthcare providers when we recommend that people should lose weight is the fact that many of us are already overweight. So it's kind of tough and embarrassing when you walk into the room and be harsh on one of your patients and ask him that he really has to try very hard in order to lose weight, and probably he will look at you, why you don't tell yourself? Today I'm going to talk about something different from what you used to hear from people talking about fatty liver. You're familiar with NAFLD, but you're probably not familiar with NOFLD. NOFLD is a terminology I came up with like 3 years ago, which means non-obese fatty liver disease, NOFLD. Let me tell you something. The terminology NAFLD, which you all are familiar with, is a wrong one. Why? Because this terminology assumes that the main cause for fatty liver is alcohol, and everything else has to be non-alcoholic. This is wrong. And that's why I came up with the terminology NOFLD, because the true terminology, the right terminology, the accurate terminology should be OFLD, obese liver disease or non-obese liver disease. Under non-obese liver disease, you can include alcoholic liver disease, but you cannot name this epidemic, the disease which is the most common cause for chronic liver disease in the world, affecting 75% of chronic liver disease patients. You call them non-alcoholic liver disease. That's not true, and that's not fair. It's either OFLD, which is obese fatty liver disease, or non-obese fatty liver disease, NOFLD. Fatty liver can affect skinny patients, and you don't have to be obese or overweight in order to get fatty liver. To make it simple, always remember this picture. Not everyone with a liver disease has yellow eyes or jaundice, and not everyone with yellow eyes necessarily has a liver disease. Similarly, not everyone who's overweight or obese has fatty liver, and not everyone with fatty liver has to be obese. Non-obese fatty liver disease, or fatty liver in non-obese patients. It can happen at any age. It can be associated with an array of disorders: genetic, autoimmune, metabolic, and associated with drug toxicity. Because it's kind of a wastebasket, it includes too many categories. It's difficult to characterize the pathogenesis, clinical features, treatment, and prognosis. You cannot generalize pathogenesis to all these disorders. How common is it? In Italy, it is found in 16% of lean non-drinkers. And in Italy, too, 22% of fatty liver non-diabetic patients have fatty changes. And in Italy, 1 in 8 fatty liver patients has normal BMI. So there is no obesity and there is no overweight. In India, there was an interesting study which was done in a rural area with a low fatty liver prevalence. And they found that 75% of the fatty liver patients had BMI lower than 25 kilogram per square meter. So 75%, that's kind of impressive. Why does it happen? It's not completely understood. It can be related to genetic factors. Several markers have been identified, especially BNB-LA3, but these markers haven't been validated. Could it be related to diet? People, lean people actually with fatty liver tend to consume more soft drinks, eat more meat, more fat, more cholesterol, more carbs, but less polyunsaturated fatty acids. Could it be related to insulin resistance? You know, if you are familiar with fatty liver, you know that it is frequently associated with insulin resistance. And again, insulin resistance doesn't necessarily mean that you are overweight or obese. You can see it independently of BMI, but who knows? It seems like the chicken and egg. Who came first, the egg or the chicken? Is it the cause or the effect? When you have insulin resistance, you get defective gluconeogenesis, which will lead to hyperglycemia, and this will stimulate lipogenesis. According to the National Health and Nutrition Examination Survey, metabolic syndrome was present in 4.6% of normal weight individuals and 22% in overweight and 59.6% in obese patients. That's expected, you know, 59.6% in obese patients to see metabolic syndrome, but I'm going to take you back to 4.6% of normal weight people, just regular, normal people. They don't have any weight issues. However, they have metabolic syndrome. So this is a new term, MONW. M, metabolically, O, obese, N, normal weight, which means that you have a normal weight, but your metabolic features is not different from those with overweight or obesity. MONW, metabolically obese, normal weight. You lose weight and you lose weight fast. Rapid weight loss, metabolic stress, increased steatosis. Steatosis will increase inflammation. Eventually, after this weight loss, steatosis will improve and disappear, but in some patients, the inflammation will go away. In some patients, it will not. Why? We are not sure. It could be related to some kind of nutritional deficiency, like essential or non-essential amino acids. It's interesting. We understand that when you lose weight fast, this is very stressful for your liver and for your metabolism. And that's why you cannot handle all the weight loss and you can get some steatosis. And naturally, if you have steatosis, you can develop inflammation. After some time, when your liver, you know, gets back on its feet, you can fight the steatosis, you can get rid of the steatosis, and you can start fighting the inflammation. But in some patients, the inflammation will continue, and the most likely explanation is nutritional deficiency. Kwashiorkor. Many of you may not be pediatricians. When I was doing my internship like 40 years ago, we used to see a lot of these kids at Cairo University Children's Hospital. Kwashiorkor is a Swahili word. It means the disease of the first child when the second one arrives. What happens in Africa is that when the woman gets pregnant, she quits breastfeeding the first child and starts feeding the second one. And instead of breastfeeding, the mother will offer the first child rice water or rice or whatever, some kind of carbohydrates. And that's why they get some kind of protein calorie malnutrition, they get hypoproteinemia. They are thin, but they have generalized edema, including ascites. So they are slim, they don't have too much fat. However, they have fatty liver. What is characteristic about these patients is abnormal amino acid profile. Celiac disease. Many of you, I'm sure, are familiar with celiac disease, some kind of gluten intolerance. When I went to medical school, they used to tell us it affects 1 in 8,000 people. Now we're down to 1 in 100. You find antibodies to gluten in blood donors, you know, about 1 in 100. This is a much common disorder than what we used to think. You know, what happens with this disease is that you eat gluten and gluten gets digested into gliadin, and gliadin under certain conditions will get into your epithelium and then induce lymphocytosis, and then will produce cytokines, and the cytokines will induce injury. Why patients with celiac disease develop fatty liver? It's common to have it. It is not different from kwashiorkor, guys. It seems to be due to some kind of permeability changes in these patients. They have intestinal disease, and this can lead to some kind of nutritional deficiency. The good news, you put the patient on gluten-free diet and the patient will improve and the steatosis will go away. Cystic fibrosis. Depending on you are, you may be familiar with cystic fibrosis or not. You know, cystic fibrosis is the most common genetic disorder, but it's much more common in the Western world. But, you know, when I start, you know, working with my friends and colleagues in Egypt, we found some cases of cystic fibrosis. It is characterized by chronic lung disease, but it can affect other organs. Thick mucus can produce chronic liver disease, but it also like thick bile, but it can affect different organs. In these patients, you're going to see a lot of liver problems. Fatty liver and other liver manifestations can be seen in 24 to 75% of patients. The mechanism is unknown. It doesn't seem to be related to the genetic defect. It may be related to insulin resistance, or it may be related like celiac disease or kwashiorkor or weight-losing surgeries to some kind of nutritional deficiency. These patients, besides lung care, they need to have very close nutritional surveillance and treatment, including well-balanced diet, fat-soluble vitamins, nutritional supplements, and in some of these patients, actually, we need to give NG feedings, and many of them will have a G-tube placement in order to provide them with what they need. Many of them actually develop cirrhosis when they are kids. We have like 3 or 4 years old, 5 years old, cystic fibrosis and end-stage liver disease. That's why we have to follow their liver very closely with an ultrasound and liver enzymes. And many of them will need orthodeoxycholic acid. Many of you here listening to us, you know, are familiar with UDCA, orthodeoxycholic acid. This bile acid has a very interesting story. What happened is that they found that people living in the North Pole, the Eskimos, you know, they don't develop gallstones. And the reason they found was that they eat polar bear gallbladder. So they analyzed the gallbladder of the polar bear and they found that orthodeoxycholic acid constitutes about 99% of the bile acids of polar bear. We also have it in our human bile, but it only constitutes about 1%. So they started using this in order to treat gallstones or prevent gallstones, and it worked very well. Besides that, it has many other effects. It is chloritic, it induces a bile flow, it is cytoprotective by displacing toxic bile acids with benign bile acids. It has mild immunosuppressive effect. That's why it can work with some of the disorders you guys see in older people. And it definitely decreases the lysogenicity by replacing some bile acids. In addition, it prevents bacterial translocation. But the one thing I would like to stress for those of you who really take care of cystic fibrosis patients is that different from other diseases associated with chronic liver disease, these patients need higher dose of orthodeoxycholic acid. TPN, we have many patients taking TPN. They are slim, they are malnourished, and however, they have fatty liver. Why? I don't think it's any different. We don't know why these patients, they are not fat, they are not obese, they are not overweight, but they still get fatty liver. You know, they can also get, besides steatosis, intrahepatic cholestasis, they can get bile duct proliferation. The pathological feature we usually see in patients with alpha-1 antitrypsin deficiency, and pediatricians see it with biliary atresia. But it seems that in patients with TPN, nothing can replace natural feeding. And that's why they can get some kind of nutritional deficiency. HCV, you know, many of you actually know much more about HCV since I'm a pediatrician, but HCV, hepatitis C virus, can be associated with steatosis. Why? Maybe because they already have risk factors. They have hepatitis C, but they also have obesity, or they have metabolic syndrome. But the virus by itself has direct cytopathic effect, which can induce steatosis. Both mechanisms can lead to progression. And an observation was that genotype 3 is more likely to have severe steatosis. The good news, you get rid of the virus, you get rid of the steatosis. The mechanism is unknown. Maybe binding of the viral X gene product to LXER alpha, and this will result in upregulation of SREBB1C. The characteristic thing about the hepatitis C virus induced steatosis, which is kind of different from the steatosis you see with obesity or risk factors, it is not zonal. Like, you know, you see with fatty liver in patients who have what people call NOFLD, which will be kind of limited to zone 3. It seems that obesity by itself has a negative impact on the SCVR. However, the effect of steatosis on the SCVR is controversial. And it seems that steatosis, unrelated to the cytopathic effect of the hepatitis C virus, can negatively impact the SCVR. So it seems the effect on the sustained viral response, you know, is affected mainly by obesity, not necessarily by steatosis. Hepatitis B is different from hepatitis C. And the prevalence of steatosis in patients with hepatitis B is not really different from general population, sometimes even less. But the interesting observation is that there seems to be some kind of a viral protective effect of hepatitis B, because there is negative association between the viral load and the steatosis. So it doesn't seem that hepatitis B can induce steatosis or make steatosis worse. And actually, there could be some kind of viral protection, hepatitis B virus, protecting against steatosis. You know, you see Wilson disease, and it's associated again with fatty changes. Many of you deal with Crohn's disease and all sorts of colitis. And sometimes, many of you, including myself, forget about the hepatobiliary manifestations. Inflammatory bowel disease or inflammatory bowel disease colitis is mainly associated with manifestations including primary sclerosing cholangitis, gallstones, portal vein thrombosis, and you use drugs to treat inflammatory bowel disease. Some of them can induce liver injury. In a big study, which included like more than 500 people, they found that hepatomegaly and mild to moderate and severe steatosis in patients with inflammatory bowel disease, between 25 and 39% in Crohn's disease, and 25 and 35% of ulcerative colitis patients. The interesting observation was that the severity of colitis correlates with fatty changes. If you control the inflammation, if you control colitis, if you get the disease under control, the fatty changes gets better. I always forget to take a good history. Sometimes I am in a hurry and I forget to ask about drugs. Drugs is one of the most critical information you get from taking history, because many of the drugs the patients are taking can induce fatty changes. So whenever you see patients who have fatty liver, either they are obese or not, because you can be obese and not necessarily have the so-called non-alcoholic fatty liver disease. You can have steatosis, which is not related to the obesity. It can be related to other disorder of all the disorders I have told you about, and it can be induced by drug. One of the most important things I would like to remind you of, a disease commonly overlooked commonly misdiagnosed: LALD, lysosomal acid lipase deficiency, an autosomal recessive disease, a genetic disease caused by defect in the Lipase gene, leads to accumulation of cholesterol esters and triglycerides in different organs: liver, spleen, adrenal glands, intestine, vascular endothelium. 50% of the patients will have adrenal calcification. The main feature beside liver disease is this lipidemia. Any age, very young, we used to call this disease in the past Wallman disease. It affects infants. They present to us with vomiting, diarrhea, cholestasis, and they die before 12 months. Or you can see it as a cause of chronic liver disease. So I would like you to keep in your mind that whenever you see a patient with unexplained liver disease, think of LALD. But the mean age in most patients, it will present around the age of 5 years. Any age, from infancy to childhood to adults. In Arabic, we say, min al-mahdi lil-lahd. Progressive liver disease, microsteatosis, which is different from non-alcoholic fatty liver disease, which is macrosteatosis, commonly overlooked, commonly confused with familial dyslipidemias, and commonly misdiagnosed with NOFLD and keratogenec cirrhosis. Here, we look at the cell. Inside the cell, we see the lysosome, and inside the lysosome is lysosomal acid lipase, which will do the hydrolysis of cholesterol esters and triglycerides. But here, in the cell, in the lysosome, inside the lysosome, there is no LAL, there is no lysosomal acid lipase. So you cannot do hydrolysis for the cholesterol ester and triglyceride. This will cause accumulation. And therefore, there is no release of free cholesterol. We couldn't really produce it. So the body will think that you are cholesterol deficient. It will send a message. You make more cholesterol. And you also try to engulf more lipids, more cholesterol in order to do the hydrolysis to release the free cholesterol. You end up with dyslipidemia, high LDL, low HDL. Here, I just want to tell you why I'm trying to get you to think of LALD, because it is not as rare as you think. It is not much different of Wilson disease. We always think of other rare metabolic disorders where LALD is more common than them. And LALD can be also different because there is a treatment. There is an approved treatment, there is a safe treatment, and it is an effective treatment. As I told you, it's a defect in the Lipase gene. The most common mutation is E8SJM, or exon 8 splice site mutation. It's found in 50 to 75%. That's why if you want to diagnose it, you cannot just look for this common mutation, because it can be messing up to 50% of the patients. There are so many mutations. The severe ones we see in infants. The severe ones we see in Wallman disease, and that's why they develop very progressive disease and they die very fast. How to diagnose it? Simple: dried blood spot, which is accurate. People used to do cultured cells, and you can also do the comprehensive sequencing of the gene, not just be restricted to the common mutation, the E8SJM, because it only affects 50 to 75%. And also, this kind of mutation is low, has low prevalence in Asian and African American. So if you do the dried blood spot, and the dried blood spot is suggestive or diagnostic, actually, of LALD, you have to confirm it by the genetic, but you don't look just for the common mutation. You do a comprehensive sequencing of the Lipase gene. Liver biopsy, microsteatosis, and now with the trichrome stain, you see fibrosis. Treatment, it has dyslipidemia. People tried statins, mixed results. Try something like ezetimibe, which decreases absorption. Case report showed it's effective. experimentally or theoretically, a lot of vitamin E can treat this disease, but it doesn't really work because you need a lot of vitamin E in order to do that. And the dose of vitamin E can have a lot of side effects. People tried stem cell, mixed results. Liver transplant is accepted, but only in the context of liver failure. Now we have the treatment. It is recombinant enzyme, and you get it by infusion every week or every 2 weeks. All you need is to provide the vaccine, the enzyme, which will do the hydrolysis of the cholesterol esters and the triglyceride, and you're gonna get the normal products which you were looking for. One more time, before I end, not everyone with liver disease has yellow eyes. Not everyone with yellow eyes has liver disease. Not everyone with obesity has fatty liver, and not everyone with fatty liver has necessarily to be overweight or obese. And don't forget lysosomal acid lipase deficiency when you have a patient with chronic liver disease and you already screen them for all the stuff you do, alpha-1 antitrypsin, Wilson, autoimmune hepatitis, viral hepatitis, drug-induced hepatitis, just to keep in your mind that you can be dealing with a lysosomal acid lipase deficiency. Lose weight. Diet and exercise is the main treatment for fatty liver. You all know this much better than me. Diet and exercise. There are a lot of drugs, you know, in the works. Nothing really has been totally approved. And there are many questions about how effective, how safe, and for how long you're going to treat these patients. The most effective treatment, the safest treatment is lose weight, but lose it slowly. Unless, you know, if you don't do that, if you lose weight a lot and over a short period of time, you're going to end up with fatty liver. And I'm going to end up with this video clip to tell you about what happens if you lose weight fast.
Some eggs, you eat some ham, you eat some butter, then brother wham, you get those chest pains, eternal rest pains from eating lipid. You see the doc, he shakes his head. With blood like this, you'll soon be dead. The fats are way up, they're gonna stay up if you eat lipid. He puts you on a diet, 500 calories. You think you'd like to try it, if there were enough to see. You lose some weight, in fact you're thin. You're in great shape, for the shape you're in, your new condition, called malnutrition, is not from lipid.
And thanks so much. And I'll be happy to answer any questions or comments you have. And I think that we have some questions here. Okay. One of the questions is, what is the best treatment for cirrhosis induced by fatty liver? I think once you reach cirrhosis, the treatment will be for the common treatment for end-stage liver disease. The thing is, I want to remind you of something, that when you reach cirrhosis, in many of the patients in whom the cirrhosis was induced by fatty liver, when you reach cirrhosis, actually you start losing the fat. The steatosis will resolve, so be careful. And that's why many of the fatty liver induced cirrhosis are called the cryptogenic cirrhosis. Is there any medication that can reverse the fibrosis induced by fatty liver? You know, I'm sure many of you have seen all these anti-fibrotic and stuff like that. I don't think they are very effective. So nothing is recommended at this point of time. Thank you for nice information. Please, I need a copy to send to by my email. Actually, I published a paper which talks about non-obese fatty liver disease, or the terminology I suggested, which is NOFLD, and also about lysosomal acid lipase. And the main reason of my talk today was to remind you that fatty liver doesn't necessarily mean obese patient. And the second thing is that don't forget lysosomal acid lipase. I'll be happy to send a copy to anyone who's interested. Just if you can just send the email, I'll be honored to do that. Do you recommend, another question, you recommend lose weight slowly. That means that you don't agree with bariatrics intervention. That's not really what I meant, and I hope I didn't lead you to this conclusion. Definitely, when you go for surgery, you have reached the stage where you really probably failed other therapeutic modalities, and especially in pediatrics, and you are dealing with a lot of comorbidities. So basically, you have to, again, like what we do in medicine, we weigh the risks and the benefits. So basically, you know, dealing with all these life-threatening or chronic conditions and getting more steatosis. So that's not really what I meant. What about this recent trial, OCA for NASH? It's very close. OCA or obeticholic acid, you know, is getting very close. I think we were expecting the FDA approval like 3 months ago, but maybe because of the COVID-19 epidemic, we started, it was difficult for them to come up with a decision. So the decision about approval, you know, for obeticholic acid for patients with NASH, not just steatosis, is getting very close. I think there have been encouraging results that it can help the inflammation, it can decrease fibrosis. The only side effect, well, the main side effect was itching in high dose, but I think it will be a good drug for patients with with NASH. Congratulations. In your experience, bariatric surgery in obese patients with fatty liver, has it worked? Definitely. But like I discussed, you know, you lose weight and you lose weight fast, you induce some metabolic stress, you end up with more steatosis initially, which will get better with time. But you can also develop inflammation. In some patients, it will get better. In some patients, it will get worse. And I think when you do this kind of surgery, you know, you really have to have a close nutritional follow-up. How can we manage lean patients with NASH after negative other causes? Good question. What you need to do is first find out why the patient has NASH. Is it because the patient has patient lost weight very fast and you have to follow up on that? Does the patient have inflammatory bowel disease? Does the patient have celiac disease? Should we think of cystic fibrosis? Is the patient taking a drug which can induce that? So the treatment of lean patients with fatty liver will be just taking care of the liver like you do with any other kind of chronic liver disease. And at the same time, you have to find out why the patient had NASH. Thank you. I appreciate mentioned, and I have the email. Noran, are we keeping this email so that I can send them the literature I promised with?
Yes, yes, I can send it to all the attendees.
Thanks so much. So I'm going to send it to you and you can forward to them. This will be great.
Okay.
If not obese, should lose weight? No, I think that's kind of a nice question. So someone who's lean, slim, and then he gets fatty liver. No, losing weight will not do anything. Maybe add to the problem. Just keep a healthy life and eat well, exercise, just have a normal lifestyle. Is there a protocol to use for NASH? If you have NASH, you can have NASH for different reasons. You know, even like viral infections, as I told you, chronic inflammatory bowel disease and stuff like that. But if you have NASH and it is because of obesity and not because of all the chronic problems which I told you about, then you have to do is lifestyle and diet modification And as I was telling, one of our colleagues who asked me earlier, there is a drug coming out very soon, and maybe we can try that. What level of AST and ALT to be considered high in fatty liver children? I'm really glad that Nagwa Abdullah Ismail asked this question. The characteristic feature, about fatty liver disease in children is that ALT is 1.5 the AST. Many times I get a consult, I haven't seen the patient, and I see the reason of the consult is chronic, is high liver enzymes. The first thing I look at the weight and the height. And the second thing, I look at the ratio between ALT and AST. In obese patients or overweight patients, the ALT is usually higher than the AST because you have a lot of fat inside the cell which will push the enzymes out. But remember something, this is different from the alcoholic liver disease. In alcoholic liver disease, the AST is higher than the ALT. Why? Because alcohol is a mitochondrial toxin. So it will cause mitochondrial injury, and the injury will release more AST than ALT. But I'm glad, I was asked this question because you have to remember something, is that if you look at the normal range of liver enzymes in your patients, it can be like 10 to 50. So 10 can be normal, but 50 probably can be 5 times the normal range. So basically you have a wide range for normality. And in these cases, what I do is try to find any previous lab done for this patient to see what was normal for this patient. So these patients, when they lose weight, they exercise, what I find that they used to have an ALT of 45, which is normal according to the range, but it's not normal for this patient. And after some time, after losing weight, the enzymes will go down to 10 or 15. This is what was normal for this patient. So what I would like you to do is, if you see a patient with liver enzymes, try to find out what the liver enzyme used to be. Second thing, always look at the ratio. There is no reason for the ALT to be double the AST unless something else is going on. Okay, what do you think about the pioglitazone or metformin and vitamin E to decrease inflammation and fibrosis? As pediatricians, we tried all this. It seems that in all the patients I tried that, not only me, many people, liver enzymes come down, but it doesn't seem to have an effect on the fibrosis. Will I use it? Yes, I will use it. Why? Because when the liver enzymes come down from 100 to 50 or 60, however, the fibrosis is still there. Why the liver enzymes come down? I do believe that liver enzymes come down because you did something to the inflammation. If it's not really preventing or resolving the fibrosis, in my own opinion, it's doing something to protect the liver. Thank you. What is the role of omega-3 fatty acid for the treatment of fatty liver? Omega-3 fatty acids, again, one of the things which people tried, and there is no evidence that it will help, but there is no evidence that it will hurt. Sorry, because I was a little late. I had internet problem. I have seen this. Thank you so much for the compliment. Thank you. Okay. I need a copy of the presentation. Okay. Treat HBV can stop a progression of steatosis. We're making the assumption that hepatitis B was the cause of steatosis, which is uncommon. Thanks for the lecture. I'm interested in, okay, kindly send. Thank you. What is the role of vitamin E in diabetic and no diabetic NOFLD? Again, many scientists and clinicians believe that it is some kind of fatty liver changes happen because of some kind of oxidative stress. And we all that the vitamin E is an antioxidant, and that's why people tried. I tried myself. I'm careful, however, and I want you to be careful because there are some cases which had some cardiac complication because of vitamin E. So I will use it for a short time first and see what kind of effect it has on the liver enzymes. I don't expect it to resolve the fibrosis, but it will decrease the inflammation. I wouldn't use high dose, and I'll be very careful about the cardiac manifestations. I'm interested. Okay, thanks, Prof. Thanks so much for the